Good evening to all of you. And thank you for this invitation. Thank you, Professor Chokri, for this introduction. This is, I think, a nice picture of my group, people working in my clinical world, and not all of them are involved in the COVID-19 treatment of the patient, but we had a lot of involvement, particularly in the management of the patient with cardiovascular disease, with chronic cardiovascular disease, since most of them have been, let's say, treated in our department or in our medical department, pretty much connected with my unit. Basically, what is the COVID infection has been already described in this beautiful lecture by Lorenzo, and you know very well that it's probably the worst pandemic of the last century, and the agent is the beta coronavirus, pretty much similar to the one of the SARS and the MERS, the two ones that break out in the last 10 years, and that were confined to the southeast of Asia or to China. But in this case, the situation was pretty much worse, and a lot of people has been involved across the world. The symptoms are pretty clear, and Lorenzo has clearly shown what's going on, and basically most of the patients have some kind of fever combined with let's say, a nasal congestion of a dry cough, but of course, you can find patients with many different symptoms, and some of them are pretty rare, but actually, we have a lot of suspect when we see a patient with the immediate abrupt onset of any kind of symptoms that could be in some way pretty much related to the virus infection. This is the situation in Italy. Is of course the same that Lorenzo has already shown to you. It's just a different picture, and I'm sorry because of course it's in Italian. This is the overview of what has happened today. So the situation is updated to today. We have this number of cases actually in Italy. More than 200,000 people have been infected or are currently infected by the coronavirus. And I think what is terrible is the number of patients who died. About 30,000 patients died. So I don't think that this is let's say, the saddest point of this terrible situation. As has been shown by Lorenzo, most of the patients are concentrated in the Lombardy region and in the closer area to Lombardy region. In my region, which is this one, we had a remarkable number of patients. I tried to take in some recent figures which has been released tonight. We have about 27,000 patients infected by the virus, and fortunately more than 15,000 of them are recovered from the infection, but still we had about 3,800 patients who died. So I think it's a terrible balance, that is a terrible price that we had to pay to this viral infection. The only positive news is that, as you can see from my slides, from Lorenzo's slide, the infection is going to decrease, and the number of new cases is going to decrease from day to day. And we expect that we can start again living our lives maybe in 4 weeks from now. As far as the demography of the disease is, most of the patients in Italy are in the older range. You see, this is a distribution, and you would see that the larger proportion of patients have an age over 80. And probably the most recent findings have also confirmed that the large proportion of the patients infected by COVID-19 are in the elderly area. We have more males than females, and this is typical across the world, even whether the proportion between males and females has changed over time. In the very beginning of the disease, we have about 70 to 30, and now the situation is a little bit different. We are 60-40 between males and females. And as far as the severity, fortunately, most of the cases are mild. But as I've shown just before, we had a remarkable number of patients who deserve some time in the intensive care units, and so for some of them, of course, the prognosis was not good. So in terms of natural history, you know very well how the natural history of the disease is basically a condition who have two different phases. The first one, which is the viral invasion, which has been summarized very well by Lorenzo. And second one is some kind of host reaction based on the breakout of an inflammatory disease, which is responsible for the worst symptoms and the progression of the clinical disease. Some patients are pretty much related to this initial phase of the disease. They don't have any progression toward the severe degrees, and actually we don't know which one could be the factors that can support the progression from the mild disease to the most severe one. What is important, of course, is that the clinical evidence and the symptoms and all the supporting variables are pretty much different in these two populations of patients. And even the treatment has been defined in the different phase of the disease and in a different way according to the complexity of the clinical case for each patient. Actually, you know very well that one of the most, let's say, interesting, but at the same time maybe unexpected consequences of the COVID-19 syndrome was the huge involvement of the cardiovascular system. In terms of interaction between COVID and cardiovascular system, I think we have many different aspects of the disease that should be taken into account. The first one is that the possibility that COVID-19, the infection by COVID-19, is per se responsible for cardiovascular disease. It's a very important point, and we are going to get some information, some new information from day to day on this very important topic. The second point that I think is the most important for the management, for the daily management of the patient, is actually the fact that most of the patients infected by COVID-19 has a cardiovascular comorbidity. So in many of these patients, there are previous cardiovascular disease, and the infection is going to worsen the clinical condition and the clinical outcome of this patient with chronic cardiovascular disease. And after that, there are some, let's say, logistic conditions that are worsening the prognosis and the history of the cardiovascular disease in this patient. The first point is that most of these patients have been restricted at home, and usually when they go to the hospital, they have usually found some difficulties in let's say, try to find out someone which was interested in their disease, in the huge amount of patients that were crowding the hospital because of the COVID infection. The second point is that most of the doctors in the hospital have been involved in the management of the COVID syndrome. And so there were less people, less doctors and less nurses that could be dedicated to all the other patients, including the patient with cardiovascular disease. And the other point is that since most of these patients had to stay at home and the hospital had been moved from the, let's say, chronic hospital to the acute situation, the efficacy and the efficiency of the outpatient clinics, for example, were pretty much reduced. So for most of these patients, there was no possibility to be checked over time. So I think the problem of the cardiovascular disease during the COVID syndrome was not just the induction of the cardiovascular disease by the virus, but it was the environment, the cardiovascular environment, that has reduced significantly the ability to protect the cardiovascular patients. And this, I think, was a problem, considering that the cardiovascular disease are probably the most important prognostic risk factors for patients with the COVID syndrome. And this is a recent review of the population of patients which went to the hospital because of this problem. And you would see the death rate of patients with previous cardiovascular disease was more than 10 times the death rate of patients with the same syndrome, the same COVID syndrome, but without previous cardiovascular disease, with some involvement in terms of prognosis also for the most important risk factors like diabetes and hypertension. So I think the cardiovascular involvement and the cardiovascular world was pretty much and strictly related to the natural history of the COVID-19 syndrome. One of the most interesting findings that broke out from the very beginning was the possibility of the coronavirus to cause some kind of myocardial injuries per se. So not because of the worsening of the cardiovascular disease, but because of the ability of causing some kind of myocardial involvement. These are the results of 4 studies published, of course, by Chinese colleagues, because the Chinese colleagues have had some contact with the virus ahead of everybody in the world. And you would see that the rate of primary cardiovascular involvement was pretty different, but it was from 7% in the more optimistic situation to more than 20, from 20 to 30% in the most recent papers. And in this, among these papers, we paid these patients with a direct myocardial injury because of the COVID-19 syndrome. You can see some patients that have some kind of direct myocardial involvement due mainly to the cytokine release during the inflammatory phase of the disease. And another possibility that is breaking out as one of the most important features to be investigated at present and for the future is the possibility of direct primary myocarditis in these patients, or in some of them, some kind of decline in myocardial function without any involvement of coronary artery disease, something which seems pretty similar to the Takotsubo syndrome. So a huge involvement of the myocardium per se in the overall clinical syndrome of COVID-19 infection. Which one could be the mechanism? I think this is one of the most beautiful pictures that has been published, and this comes from a paper which has been published this morning, and that summarizes most of the evidence we have now in terms of cardiovascular disease and COVID-19 syndrome. And as you can see from the picture, some cardiovascular involvement can be due to the direct viral invasion of the heart, that can cause, of course, some abnormalities in the mechanism of functioning of the myocardium and the myocardial tissue. There is some possibility that the inflammatory syndrome that is associated with the COVID-19 syndrome can cause some problems in terms of circulating cytokinin, and this problem is also strictly related to some kind of immunitary reaction. And all of these, of course, conditions are able to affect the myocardium, and at the same time, they are able to affect the arterial wall and to promote some kind of instability of the atherosclerotic plaque. So finally, if you put together all these kind of possibilities of interaction between the infection and the cardiovascular system, you can see the large amount of possible evidence of cardiovascular involvement in patients with COVID-19 syndrome that goes from myocardial infarction and acute coronary syndrome to the onset of heart failure, which I think is the most insidious because the symptoms are pretty much related to the symptoms of the respiratory insufficiency of the disease. And another possible complication is the onset of arrhythmias that seems to be threatening, of course, for the patient, and probably more common than we expected at the beginning of the outbreak of the disease. how to understand, how to try to interpret the presence of some myocardial involvement. I think that from this point of view, of course, the clinical symptoms are pretty interesting, but sometimes the clinical symptoms are pretty much the same that can characterize the respiratory syndrome. So probably the biohumoral analysis, biohumoral managing of these patients is probably the most important, and in particular, the level of high sensitive cardiac troponin seems to be the most important, according to the results published from this paper, which was published at the very beginning of the outbreak of the syndrome, showing that in patients who died because the COVID-19 syndrome, there was a progressive increase in the plasma level of high sensitive troponin. So even in our particular situation, we give a lot of respect to the changes in the level of troponin, and every change, and when the troponin is starting to increase when compared to the baseline condition, is a very important and reliable sign that some involvement of the cardiovascular system, and in particular some involvement of the heart in the overall syndrome of COVID-19 infection. Just a few words on which one could be the main mechanism behind the cardiovascular involvement in patients with COVID-19 syndrome. I think many hypotheses has been put forward. Of course, one of the most interesting and I think most attracting is the possibility of some kind of imbalance within the mechanism of renin-angiotensin system. In particular, most of the papers now are moving toward the support to the hypothesis that what we see is probably the final results of an imbalance between the downregulation of the ACE2 system, which is the, let's say, the binding point for the virus, and the overexpression of the renin-angiotensin system, and in particular the overexpression of angiotensin 2. And in this particular situation, the overexpression of angiotensin 2 is unopposed by other counter-regulatory mechanisms like the ACE2 is probably responsible for the vascular damage, for some kind of cardiac damage, and for some kind of enhancement or the amplification of other mechanisms that can directly and indirectly infect the cardiovascular system. This is a very interesting point, I think. Is also a very interesting perspective for the future, and trying to understand if the modulation of the renin-angiotensin system can be a good strategy for the treatment of patients with COVID-19 syndrome, and also, of course, for the prevention of long-term cardiovascular complications that I think we should expect in this very important population of patients. Certainly, the involvement of the renin-angiotensin system is pretty clear, particularly from this nice paper that clearly shown that infection of COVID-19 is associated with a significant increase in the plasma level of angiotensin 2, and the level of angiotensin 2 are inversely or directly correlated to the, let's say, the level of virus load, and on the other side to the decline of the respiratory function, which has been pretty clear presented by Lorenzo in his talk. So we have a lot of angiotensin circulating in those patients who have the worst complication, and the level of angiotensin is in some way related on one side to the infection, and on the other side to the consequences of this infection on the main target organ, which is the lung. And of course, this can happen at different levels, because the same mismatch between angiotensin 2 and counter-regulatory mechanisms can happen at the different level of the body, but in particular at the level of the endothelial wall, and at the level of the cardiovascular system, at the level of the renal system. And if you put together all this information, you can clearly explain why these patients have at the same time abnormalities of the respiratory function, renal function, and multi-organ involvement. It's just an hypothesis, but it's pretty much supported by all the literature which has been published during the last, let's say, 10 days. So, provided that we know that we have some cardiovascular involvement in this patient, and that maybe we have so many different mechanisms, but probably the cardiovascular mechanism seems to be relevant, even in terms of prognosis. Let's try to see what's to do in terms of management of cardiovascular disease in this patient. Of course, what we have to do during the acute phase has been already shown by Lorenzo. Lorenzo is a, let's say, is a large experience in the management of this kind of patient. I will go through the treatment of some of the, let's say, chronic diseases and the use of drugs which are currently used for the management of cardiovascular disease, and how they can apply to the treatment of patients with the COVID syndrome infection. I don't want to go into the treatment of acute coronary syndrome because I know that our friend from Egypt knows much better than me, so I will skip this slide. I would like to go directly to the treatment of hypertension. And the treatment of hypertension actually is not different in patients with COVID infection when compared to the other ones. So there are no specific guidelines for the treatment of this patient in terms of which drug should be used and which strategy should be used in terms of drug of choice, which again seems to be the drug inhibiting the renin-angiotensin system that can combine with the calcium channel blocker and the diuretics, depending, of course, on many different factors, and in particular depending on the condition of the patient. Of course, when you treat hypertension in this population of patients, you don't have only take care of the which one is the treatment, which one is the target. There are some specific conditions that we have to take into consideration and try to get some practical suggestion on how to manage hypertensive patients in this peculiar situation. First of all, the suggestions that we can get from the guidelines do not apply to the patient in the intensive care units, which are managed as the Lorenzo has shown, and which are usually managed according to the acute condition. The drugs we have seen are those which are usually recommended by all the guidelines. So the first line drugs for the treatment of patients with hypertension and COVID infection are exactly the same. In particular, of course, drug inhibiting the renin-angiotensin system seems to be the most relevant. When we decide the therapeutic strategy, we don't have to take care only of the patient's, let's say, blood pressure levels and of the level of cardiovascular risk, but we have to take into consideration the age and the clinical and hemodynamic condition of these patients. Most of them are hypertensive, or they have a spontaneous reduction in blood pressure because of the infection and because of the acute disease. So maybe they don't need any antihypertensive treatment during the acute phase. We have to consider the clinical history, because depending on the type of patients and on the level and the type of comorbidities, the drugs that we are going to use should be differentiated from patient to patient. And we have to take care of the chronic, acute and chronic target organ damage. This patient can have a target organ, the previous target organ damage, or they can develop the same during the acute phase. And actually, what is important, of course, is the drug administration that is clearly dependent on the overall condition of the patient. Actually, no major interaction has been described for the many antihypertensive drugs that are currently used for the treatment of hypertension in this patient, except some probably interaction at the level of QT elongation in patients treated with chloroquine and hydroxychloroquine and beta blockers. In terms of monotherapy and combination, the recommendations are exactly the same that are reported by the guidelines. And what about the target? The target blood pressure, I think, is not so important during the acute phase. And during the recovery phase, or in patient who doesn't have hypertension, the target of blood pressure is exactly the same. That is, we decided for the patient outside the COVID syndrome. Certainly, the use of drug inhibiting the renin-angiotensin system seems to be the most important, not only because of they intercept the mechanism of action of the disease, but also because of some studies which has been published in the past and showing the evidence that these kind of drugs are probably able to favorably interfere with the respiratory disease and in particular for ACE inhibitors. There are a couple of epidemiological studies showing a significant protection of the respiratory tissue in patients treated with angiotensin-converting enzyme. The second classes of drug we have to take into account when we treat chronic patients infected by the COVID-19 virus are statins. Statins certainly are pretty much useful for the management of atherosclerotic disease, in particular considering that in these patients we observe some kinds of instability of the atherosclerotic plaque. So the possibility, the capacity of stabilizing the atherosclerotic plaque, I think, could be very important. In particular, some experimental studies seem to suggest also some direct interaction between the statins and the mechanism of action of the coronavirus. So we could have even some advantages in terms of interaction with the natural history of the disease. Certainly, the statins don't have only some kind of effect in terms of reduction of serum cholesterol, but all of you knows very well, for example, the anti-inflammatory properties of statins, the possibility of playing some role in the endothelial protection, and the ability to play some role in terms of antithrombotic effect. That seems to be very important since the overall clinical profile of this disease is based on, let's say, inflammation, endothelial dysfunction, and prothrombotic effect, in which the statins can play some remarkable role beyond their effect on the cholesterol level profile. This is probably the reason why a very nice flow chart, which has been proposed by the Massachusetts General Hospital a couple of weeks ago for the management of these patients, suggested the use of statins not just for the treatment of coronary artery disease, but as an additional treatment in terms of improving the clinical prognosis of patients with COVID-19 syndrome. Actually, I think the last 4 days ago, 3 very important papers have been published on the New England Journal of Medicine dealing on the effect of chronic treatment of cardiovascular drugs in patients with COVID-19 syndrome. And I don't want to go into this paper because probably they will be treated later on this afternoon, but just to remember that since we have suggested that in patients with chronic cardiovascular disease, the use of drug inhibiting the renin-angiotensin system and statin can be very useful, I would like to point out on this very nice paper that is clearly suggesting, even on the, let's say, retrospective analysis, but a huge population of patients from across the world that suggesting that patients previously treated with ACE inhibitors and previously treated with statins can have, let's say, an improvement in the clinical prognosis when infected by the COVID-19 syndrome. For the other drugs, I think I have nothing to say beyond the analysis which has been done by Lorenzo in his beautiful lecture. Just to remember the problem of the possible interaction between hydroxychloroquine and azithromycin, since this protocol was used from the very beginning in many of the patients with the COVID-19 syndrome. And now in Italy, we have decided not to go on because there was a significant increase in the risk of prolongation of the QTc in our patient. And this is pretty clear for this patient. From this paper published on JAMA and showing that the hydroxychloroquine is able to cause prolongation of QTc in some patients, but the number of patients with a prolongation of QTc is definitely higher when you combine the hydroxychloroquine with the azithromycin. Nothing to say about the convalescent plasma. This is a very debated topic, even in Italy. In Italy, we have 2 centers, particularly in Lombardy, which are following this kind of strategy. And there is a lot of discussion about this kind of approach. This is a very preliminary report published on JAMA by the Chinese group that suggests that the possibility of achieving an improvement in the clinical outcome of treating patients with this strategy that now is used only for the more severe patient affected by COVID-19 syndrome. It doesn't have nothing specifically related to the treatment of cardiovascular disease. And this is my last slide, just to remember that, of course, when we are facing a disease that we don't know, when we are facing with a microorganism that we don't know, we have many different doses where we can open. In this terrible experience in Italy, we have tried to find out which one was the right one. We have understood something about the disease and about the cardiovascular involvement of the disease, but maybe there is something interesting even beyond the other dose. And I think that the next data that will come and the better analysis of the huge amount of data we have accumulated during the last 3 months maybe will give us the dimension on how to manage this problem. I don't think in the future, but for the other areas, for the other countries in which the COVID pandemic is just outbreak. Thank you very much.
Second question, I need to ask Dr. Claudio about, do you have any recorded cases of relapse after recovery?
Any recorded cases of?
Relapse after recovery.
No, not now. I think that is a very important question because it's one of the most debated topics now because we don't know exactly what's going on with the antibodies. We are starting with looking for antibodies in our patient, and we have started with a huge survey in the nation. And we don't know exactly which one is the situation, if these antibodies are really protected and for how long. But actually, I think there are just a few cases described in Korea of patients which were negative on the nasal pharyngeal swab, and after recovery, they have been again positive. So we actually don't know if it was matter of the technology for the research of the virus, or if they can actually reinfect it. What is pretty peculiar of this patient that it seems that they could be again positive to the infection without any symptoms, even whether they had symptoms in the first case of the disease. So actually, I think that over a period of short time, the possibility of a relapse doesn't seem so reliable. But we don't know exactly how long the protection from antibodies will last. We don't have enough experience and we don't have enough data from this point of view, because there is a nice paper on Nature which was based on the, let's say, time course of the antibodies response, which seems to be pretty different from patient to patient. But what we don't know is how long do they last, because we don't have enough, let's say, follow-up. Maybe some people, some friends, some colleagues from China will know, but not in Italy.
Okay, another question for you, Dr. Claudio. Do you have an explanation for the higher incidence of spread of the disease in the developed countries than in the developing countries?
Actually, we don't have a specific explanation, because we have some difficulties even to explain why there is a lot of difference in Italy in terms of spreading of the disease between some regions in the northern part and the regions in the southern part. Of course, the disease broke out in the north. And in the north, we have a lot of people. The cities are pretty much crowded, but not just Milan, but even the other cities around. So I think that there was a possibility that the virus has circulated into the community before the clinical outbreak of the first patient. This would allow to the virus to infect a lot of people, and most of these people keep on staying together for a very long time before the closeout of the nations. In the southern part of Italy, probably there was no infection from the very beginning, and probably no huge amount of people has moved from north to south. So probably the population condition are pretty much different from one side to the other one, but it's just a speculation because we don't know exactly what's going on. Someone suggested, for example, that it was the air pollution, which is pretty much different in the northern part of the country than in the southern part. But what is pretty interesting is that if you look at all the other nations in Europe, the trend seems to be exactly the same. In the northern part of the country, whether it's France or Germany or the Netherlands or Spain, there is always a larger number of clinical cases than in the southern part of the country. So I think there is something which is more related to
Actually,
the environment. I don't think the food, because the food is different, but and maybe in the pollution of the air could play some role, because usually the northern part of the country is more industrialized than the southern part. But we don't have an explanation. It's still a mystery.
yes.
There is one question from on the use of antiplatelets. Do you have any experience in antiplatelets as protection? Because I think it's a thrombotic event, not rather platelet event. What do you think?
Can I start, Claudio, and then you can...
No.
Okay.
What I can say is that we don't have any specific data. You mentioned that it's a thrombotic disease. The problem is it's a matter of coagulation. It's not a problem of platelets. So I think if the patient has a specific indication for the antiplatelet drug because of coronary artery disease or because he's going an invasive procedure, we can use it unless there is a risk of bleeding, which is could be related to the, let's say, severe condition of some of these patients. In terms of possibility to get some benefit from the antiplatelets drug, a couple of these papers published on the New England have also taken into consideration the impact of antiplatelet drugs, and the effect was, in terms of survival, in terms of progression of the disease, absolutely neutral. So we can expect that the antiplatelet drugs are working very well in terms of prevention of relapses of cardiovascular disease, but we shouldn't expect any ability of the antiplatelet drugs to interfere with the natural history of the COVID-19 syndrome.
Well, I read a recent article stating that the prognosis is equivalent to the platelet figures, and those having platelets below 100,000 are at high risk of complications, and that's why a dual antiplatelet at that time is not that recommended, because the platelet function is important in these situations.
Yeah, and one important thing that I think we have achieved from our experience, and probably Lorenzo much more than me, is the fact that we have to avoid any avoidable complication, because managing these patients is very difficult when you have to do any kind of procedure. What is simple in your patient in daily life, it became very difficult in patients with COVID-19, because you have to dedicated doctors, dedicated nurses, dedicated environment. And if you have to check for something, even if you have to look for some bleeding in the gastrointestinal tract, it's not very easy to do it. It's not as easy as it was in the common life. And we see even in patients with coronary artery disease, because since the possibility of going to the cath lab is not easy available for all the patients, in our hospital we are going to do some choice. And across the world, there was a strong suggestion for using thrombolysis in many patients instead of primary PCA, because there is no possibility to apply all the same number of procedures to the patient. So actually, I think we have to treat our patient, but we have to pay a lot of attention to the drug interaction, to the drug side effects, because anytime you need some rescue procedure, it can be very difficult because of the organization of the procedure.